And morning, everybody. And I'd happily add my compliments on the enhanced community care programme and progress there. I want to focus mostly today on staffing and workforce planning. But sorry, just before I do, Mr. Watt, last time we met, you undertook to create an estimate for the implementation of Sláintecare, and I'm just wondering, do you have that there?
I think we wrote back to you, Deputy, did we, setting out our views on it? I think we did send something back. Did we send something back?
What are your? Sorry, maybe we can just we can park it with. No, I don't want to park it, but you know your views on it, so maybe you can just tell me your views on it.
Sorry, my views on what? Sorry.
On providing an estimate for the implementation of Sláintecare to the committee, or to IFAC, as was
like we
mentioned in that discussion.
So we debated. So Sláintecare has many different aspects. So if you look at improving capacity within the system, both increasing the numbers of people and the number of beds, there's very significant additional costs that have gone into the system, 6-7 billion over the last 5-6 years. A lot of that is Sláintecare in relation to workforce, capacity, beds. And there's the infrastructure cost, and we've spoken this morning about some of the 4 elective hospitals. There's the enhanced community care programme, which we'll talk about more detail this morning. That's had a cost. There's the digital agenda that has a cost. So it cuts across all aspects of the budget. So I don't think you can take out.
But it is a standalone government programme. So, and you did undertake in December to create an estimate, given all those concerns.
Yeah, I think we did right, but I'll check and come back, Chair. I think we did right, but I'll come back.
So can I take it from that you don't have an estimate for the cost of Sláintecare?
But Deputy, the Sláintecare cuts across all dimensions.
No, I take that point.
So it's not. Yeah. It's very hard to say of the 24 billion health spend, how much of it is Sláintecare and how much of it is. Like if Sláintecare ultimately is an all-encompassing programme of reform in terms of integrated care, improve affordability, universal care, increase capacity.
What's that issue is, do we know how much we need to invest in Sláintecare to get to the finishing line? And are you telling me that you can't give me a number which is over and above what we would have spent on healthcare otherwise?
So in terms of the additional spend, so you'd have to look at the different elements of it. So in terms of universal health
sorry,
care.
Mr. Watt, it's just because I have very little time and I do want to move on to the staffing thing. Okay. I don't particularly want the individual elements of it. What we discussed in December was the standalone programme of implementing Sláintecare, which is a main policy thrust of successive governments. Coming from a budgetary oversight position, you would want to know what the cost of that policy is, and you undertook to look at that, and I believe you were going to either provide that information to us or to IFAC. Is it the case that that's not in front of you right now?
Let me come back, Chair, and I'll check on that. I thought we did respond.
All right, okay. So if we can then move on to staffing, I suppose I was reading through the documents, and something that struck me based on some of the conversations that we've had in this committee room recently is obviously we're talking a lot about clinical care, but I wonder if somebody could give me some information around staffing requirements into the future for ICT and data management, and what is the workforce planning on that for the health service?
So as part of as I mentioned earlier, in terms of strategies, whatever they are, and addressing cyber obviously would be a major one for us. Our e-health colleagues would, working with the department, project what is required in the ICT and data space in terms of staffing. There has been a significant investment in staffing in the last couple of years in that area, including this year. In terms of,
do you have any numbers in front of you in terms of the increase?
In terms of the increase,
yeah,
I can probably get that for you in a moment.
Okay, and if we could have a projection of what's expected separately, I suppose ICT is slightly separate to data management, because obviously there are some, there are some disciplines where data management is actually part of the service, the actual medical service. I'm thinking of things like genetics, where data management is required as part of the medical service. So if we can have a breakdown of ICT increases in and around like the last year, that medium-term frame, but also into the future, because we have spoken in this committee recently of the very significant investment by both bodies here today in ICT and the future of data as it relates to the health service, and I would be expecting to see some fairly significant staffing requirements for that. I suppose in some ways then that brings me on to staffing as it relates to I suppose consultants and management. Mr. Gloucester, that came up in May this year where there was, I know you made some comments around, and I'm careful about the use of consultants in this context, consultant management, and the outsourcing of that to private sector. And I think you identified that as maybe a cost risk, but also a structural issue. So I'm wondering, in terms of work, the corollary to that then for me would be some of that should be happening in-house.
That's right.
Okay. So if we want to get a handle on our costs there, what would you be expecting to see in terms of management consulting in-house, and how are we managing that in terms of workforce planning? So I presume we're going to have to take on people who are doing things that private firms are doing for the HSE right now.
Yeah. So in the management consulting piece, you're quite correct that I raised that, and I was talking about figures in the region of between 120 and 180 million euro of expenditure in that profile.
That was Cork, right? Or that was a specific area, was it?
Oh no, that's nationwide.
Okay.
Nationwide. So I've since managed to have that distilled down into what are actually service providers as opposed to management consultants who come in and provide us with staff or expertise. And the figure is probably in the region of about 113 million is where my target focus is.
So 113 million of that is management consultants, and then that leaves...
It's about 400 people, essentially, of different skill sets.
And that leaves 60 odd million, which would be service providers. So is that part-time staff or locums or...?
They could be various types of service. They could be providing a call centre for something or whatever.
Okay.
But the 113 million are what we call traditional management consultants, project management and so on.
So let's say if you have a capital project, for example, they're
exactly.
doing a review of that. Okay.
Exactly. So it's about 400 people would equate to the 113 million.
And sorry, I don't mean to cut across you now, but that's interesting information. But when you say there's 400 people, are you implying there that there's like 400 people who are effectively working full-time in a role that services the HSE, or is it just part of a contract?
They're not all full-time. They're very varied.
Yeah. Sorry, go on.
But to equally, our management admin category of staff has increased. It's the highest percentage increase since 2019. So I would expect that should be reducing the dependency on management consulting as we recruit particularly senior staff and skill sets ourselves. Doesn't always follow, one doesn't follow the other. But what I have done, having assessed it, and I did say the last time I was here I would do that, in terms of cost reduction and reduced dependency, I've given the CFO a target this week, in fact, to reduce that 113 million expenditure by 30%.
Okay.
30% commenced in September for the last quarter of this year, and the full year effect of that would obviously be 40 million. I'm satisfied we should be able to reduce that dependency without interfering with our progress or our development, and I'm satisfied we should have enough people in-house to meet that supplement. After that, I'd have to look at it further. Basically, our dependency has just grown too high.
Okay. And when you say the dependency has grown too high, you are then talking about bringing all of those same reports and that same work is happening in-house. It's not that same level of oversight wouldn't be done, because obviously we still need the independent oversight of projects.
Yes, where we need independent oversight or particular skill and expertise. So, for example, you mentioned the technology, e-health and ICT. This year, what we would call our chief technology service is provided from outsource because we just didn't have a person. Last week I did the shortlisting with the department for the recruitment of a chief technology and transformation officer, so we will bring that person in-house and we will then reduce and negate the cost to have that in as a management consulting. Okay.
And then finally, because I've only a minute left, I just want to move on to kind of retention of staff issues. And both in the last section there, you talked a little bit about kind of a joined up or a more robust workforce planning role and reporting in September. I wonder, can I ask if the issue of housing has come up? Obviously, I'm from a constituency where there's some very significant, I'm Dublin Central, so there's very significant healthcare facilities. I know that some of them are looking at what equates to almost, semi-permanent or long stay places where people, particularly for people coming into the country, can stay for 12 to 18 months, often because medical staff actually have to rotate to different facilities. It strikes me very similar to a university who provides housing for lecturers. It does seem to me, though, by not being proactive on this, we are to some extent possibly leaving those hospital groups at the mercy of vulture funds if we don't step in, and there might be good work to be done in terms of providing that kind of a programme, whether it be short-term housing or some kind of outreach or top-up for investment on land that they have available. Has anybody thought of that? Is that on the agenda for the department? Is that on the agenda for the HSE?
Yeah, so there was a feasibility study commenced in the HSE on that issue. When I last addressed that issue in here, I think you made it clear that either building or providing housing wasn't our core skill set, and I need to keep my focus on building hospital beds and services. That said, we have a feasibility piece which I met one of our senior staff on yesterday, which I hope to have concluded very shortly. Essentially, yes, it is going to say that accommodation is part of the issue that contributes to recruitment and retention challenges. I don't think we could get to a scale of addressing that directly. Where I believe the best possible outcome for us is with the Land Development Agency, who are negotiating with us to take available healthcare lands for developing in accordance with their statutory brief. And I would expect that as part of that and in return for that they would provide in any accommodation or housing they built, that they would factor in the local health community, particularly on those lands. That's the first thing. The second thing is the Minister did agree last month in policy principle to look at the possibility of us assisting in some way with the accommodation challenge for 3 groups of people. They're the people who come in, as the Secretary-General said, from abroad that we recruit and who find the first few months challenging. Student nurses in their final intern year, and non-consultant hospital doctors on 6-monthly rotation who are particularly challenged. If we could assist those 3 groups, I think we would make a contribution towards retention. But to be fair to government, I haven't given them a proposal on that yet for them to consider and work on. It's very complex because you have equity issues. Once you get into it, who do you give it to, who do you not give it to, and so on. And I do believe, apart from the Land Development Agency, if we were to go into that space, it would be people like approved housing bodies that I would be relying on to try and help us, because, as I said, we wouldn't make a very good landlord ourselves.
Sorry, Chair, can I just get an answer from the department on that issue? Because I think Mr. Gloucester is right. It's more appropriately a question for them.
In terms of housing, like this is obviously there's an issue about housing that impacts upon our ability to recruit people. Deputy, absolutely. As the CEO said, we're primarily in the business of healthcare policy and policy of healthcare and delivering services. You know, housing is obviously a matter for another department, but obviously we work with the Department of Housing, and there are solutions that can address some of the challenges we face. We can explore. So,
sorry, just for clarity, you're saying that it's the responsibility of the Department of Housing to deal with hospitals who want to invest in this area?
No, it's also they work with them together. I don't have any visibility on, Deputy, what's actually happening. I know hospitals do have their plans, and I'm aware that in the matter there's a particular issue there, and they've been trying to address. I'm just saying, it's to be very clear, we can work with them, and the hospitals can do, but we're in the business of healthcare, you know, and it's a very challenging portfolio that we have and the HSE have. But clearly, if the hospitals and the housing department can work together, absolutely we'll support that in any way we can.
Okay, the question was asked by yourself, Neasa, in relation to the estimate cost of the implementation of Sláintecare. The department wrote back to us on the 30th of March. And the cumulative investment in Sláintecare reforms, new developments over the period of 2020 to 23 amounts to 1.995 billion.
Thank you, Chair, but can I just point out that during that conversation we talked about it was budgetary oversight, so it's a 3 to 5 year medium to long term forecast that we were asking for, not current spending.
Okay, well anyway that letter was on the 30th of March anyway. That
didn't answer the question, so
okay.
Thanks.
And there's a breakdown then of Sláintecare, how you know the potential funding over that 3 year period. Okay, thanks very much.